Okay. بسم الله الرحمن الرحيم. الحمد لله رب العالمين وصلى الله وسلم وبارك على نبينا محمد وعلى آله وصحبه وسلم. Welcome you all to the continuous medical education of the Oman Medical Specialty Board and Oman Family Medicine Society, and the Nizwa Healthy Lifestyle Project and the Dakhlya Healthcare Committee. Our session today will be about the Nafld with an expert on this field, Dr. Khalid Al-Naamani. And this session will be like 1 hour. We'll have like 30 minutes to 45 minutes presentation. Of course, as usual, we have polls. I urge you to participate with the polls. You can put your questions all through the presentation so we can answer it by the end on the Q&As. The session is almost be accredited by 0.5 hours for the attendees, and you need to attend at least 30 minutes. On this session will be recorded on the YouTube. After like 3 days, you can find it in our channel on the YouTube. Dr. Khalid Al-Naamani, he is having his medical specialty, his FRCPC, and he's also senior consultant hepatologist and liver transplantation in the Armed Forces Hospital. The floor is yours, Dr. Khalid, and please have a start.
Thank you very much, Zahir, for the introduction, and I really so happy to be with you today to share a few slides about Nafld, and since becoming a major topic in the practice of hepatology. I don't know how's the transmission, but at one point I was having a lot of echoes, so if this continues, we may close the video and we will go just only on audio.
Yeah.
So I will start with a case, and then we'll try to solve this case at the end of this presentation. And I think this is a common case faced by most primary care physician. This is a 54-year-old male who is hypertensive, receiving lisinopril 10 milligram per day. He has got a family history of type 2 diabetes and cardiovascular diseases. And if you see from the slides on or basically the other half of the slide, this patient having high BMI and having high fasting glucose, high A1C, and he's having mildly elevated liver enzymes, ALT and AST. And secondary causes of liver diseases such as viral hepatitis, metabolic liver diseases has been ruled out. And as I just mentioned, his examination was unremarkable except for high BMI. A couple of questions may arise during your practice, and we'll try to solve them at the end of this presentation. Would you order any additional tests apart from what you saw just a few seconds, such as ultrasound, CT scan, and new modality called elastography, which I will explain it later on. Would you go for liver biopsy? What are his cardiovascular risk factors? Does he have a high cardiovascular risk? Should he be on statin? And would it be safe to start somebody on statin with that magnitude of elevation in liver enzymes? And what would be the expected benefit of lifestyle intervention, such as bariatric surgery or other liver protective medications such as vitamin E, bioglitazone, and later on. So I'll answer those questions at the end of this presentation. So what is your role as a primary care physician in the management of Nafld? And I quoted only one study down there at the foot of the slide, but however, there are more studies from Europe, which shows, unfortunately, primary care physicians, and this is not just only applied to primary care physicians, to be honest with you, but applied even to internists and even to some gastroenterologists. They still miss most patients of non-alcoholic steatohepatitis. On top of that, there is inadequate monitoring of those patients. And, you know, I won't blame anyone, and that's because of the heavy practice, and most of the primary care physicians and internists, gastroenterologists tend to concentrate on certain diseases that have high mortality. But during this presentation, I will show you that this disease is not a benign disease, and it's been associated with high liver and non-liver related mortality. I put here a few reasons quoted from those studies why primary care physicians missed or quite good number of those patients. And some of them are unaware of Nafld and Nash as a harmful disease. Diagnosis is not considered when risk factors are present. And the need for liver biopsy is not done. And I think because of the setup itself and required high setup hospitals to do a liver biopsy, and awareness of a lot of primary care physicians that there are several treatment options exist for Nash and Nafld. Through this presentation, I'll take you through the epidemiology of Nafld pathogenesis, but I will not spend much of the time. I will try to sail through different aspects of this presentation. We'll talk a bit about natural history, presentation, whom to screen, diagnostic strategies, and then at the end with the management. And I hope with all of these, I'll cover most aspects of Nash or Nafld. So what is the definition of Nafld? And it's defined as accumulation of fat in more than 5% of the hepatocytes based on liver biopsy. Some experts, they manipulate that definition. This is excess fat accumulation more than 6% if you are using certain technologies such as MRI, and a special kind of MRI such as the quantitative fat water selective MRI. So you see from this definition that there is a need for a bit of high-tech machineries, or sometimes high need for high setup in order to define Nafld exactly. So a new entity appeared over the last couple of years, describing something called lean Nash. And what is lean Nash? This is the presence of non-alcoholic fatty liver disease in people who has got normal to low BMI. It's around 7% of normal weight persons. It's mainly described in Asia, especially Southeast Asians and Indian subcontinents. It's been associated with genetic background, and by this time there are more than 60, 70 genes being discovered that predispose patients to develop Nafld, the most important of which is the PNPLA3, which has been associated even with the severity of Nafld and with a higher risk of complication in those patients who has got Nafld and positive for PNPLA3. And some study shows even those patients have low BMI, but there is some improvement in their Nafld with a change or modification of lifestyle. So we'll start with the first question, and maybe Dr. Zahir would like to do the bull for that question. So I think probably we'll...
Yeah, please, go ahead.
Yeah, maybe I think 30 seconds, Dr. Zahir, to answer this question, and then we'll look at the answer.
Yeah.
So we need you to match the terms to the description. So the first one, what is that? That's called includes steatosis and steatohepatitis. And what is the name for the steatosis and steatohepatitis?
We have almost 30% responders. I think could be the setup of the question could be confusing. You can go ahead.
Okay. For that reason, I put these questions. So the answer is basically the last one. And sorry, we put them all. Yeah, which is like.
No, shall we stop the vote, Dr. Khalid?
Yes, please. Yes.
Okay.
Please.
Now we can see the result, and people can share. Now, Dr. Khalid, you can explain.
Okay, so we'll go to the question itself, and we'll stop I think the sharing, Zahir, and
yeah.
Okay. Okay, so the question is.
Okay, give me again the permission to control a bit, so I can get back to it.
Approve. Okay, thanks.
Okay. Now you can get it back, Dr. Khalid.
No, I'm still unable.
Okay, just a moment. Again, we'll do request remote control.
Approve.
Okay.
Okay.
So there's a next slide. You can go. Can you click on it? There's downstairs on the arrow. You can click on them.
It's still not. Okay. So much the description. So the first one is basically A, is a steatosis and steatohepatitis. So that includes the whole spectrum of Nafld. So second one, B, is steatosis, and that's we call it Nafld without the D. And C is steatohepatitis, which is non-alcoholic steatohepatitis, which is basically Nash. So the answer is basically the last one. I think around more than 56% answer it rightly. We'll go to the second phase. So as I just mentioned, Nafld is not only one disease, is a continuum, is a spectrum that starts with the steatosis, which is basically simple just fat deposition, and that include around 70% of the patient who has got Nafld. In certain patients that can progress to steatohepatitis, we call it Nash, which is characterized by inflammation and some hepatocyte degeneration or ballooning on top of steatosis. And actually this form of Nafld that tend to progress faster toward increasing fibrosis and then liver cirrhosis and associated with more complications. So looking at the estimated global prevalence of Nafld, it is based on studies that use different modalities to diagnose Nafld, such as ultrasound, CT scan, MRIs, and here we're quoting a paper published in 2016 by one of the most famous guys in Nafld from United States, where they quoted more than 45 studies. And the global prevalence is estimated to be around 25%. However, unfortunately, the highest prevalence is 32. It's coming from Middle East and especially the Gulf countries, higher prevalence of diabetes, obesity in Kuwait, Saudi Arabia, Qatar, and United Emirates. And of no surprise, because of the food availability and people moving around, the lowest prevalence is from Africa. So it is not just only the Middle East, but the prevalence of obesity is increasing in majority of countries around the world. And I'm quoting you the prevalence of obesity and associated Nafld in basically in all subcontinent, North America, and from Europe, and from Asia as well. So the increase in the prevalence of obesity is associated with the highest or increase in the prevalence of Nafld. As I mentioned at the beginning, this is not a benign condition. Nafld's been associated with increase in the mortality. And you can see from this slide, which is basically, this is analysis of all-cause mortality in 6 separate studies among patients with Nafld. If you look at those patients, by the way, they've been followed for a good length of period, ranging from 13 to 14.5 years. You could see at the far left, the liver-related mortality, which is here on the red. It's very small on patient basically who has got no Nafld. But once those patients start to develop just only simple steatosis, their mortality increased. And this is true for both the liver-related mortality and cardiovascular mortality. If those patients progress farther to Nash, to steatohepatitis, where there is inflammation on top of steatosis, you could see clearly that the liver-related mortality really goes farther up. This is not just only for the mortality, but even other complications related to liver cirrhosis, such as hepatocellular carcinoma. This is data from England spanning something around 10 years, from the year 2000 and to the year 2010. And you could see clearly the hepatocellular carcinoma related to Nafld in the orange bar is increasing over the years. So again, this is not a benign condition. It's becoming now the first indication of liver transplantation around the world. It used to be hepatitis C is the first indication for liver transplantation around the world. And this is a clear data from Ohio solid organ transplantation from United States, having more than 2,000 patients. And you could see clearly from the year 2000 to the year 2010, there's exponential rise in the liver transplantation secondary to complication of Nafld. So what is the magnitude of this problem? I quoted some figures from the United States, and you could see that's clearly more than 18.2 million people with diabetes having Nafld in general, and around 6.4 million of those people having Nash, which is the progressive form of non-alcoholic fatty liver diseases. That would lead to something around 65,000 liver transplantation, more than 1.35 million cardiovascular related deaths secondary to Nafld, and 812,000 liver related deaths. The cost of all of these three things is something close to $60 billion in the healthcare system, which is equal to the Oman budget in 2020. So imagine Oman budget just only going to treat the complication of one disease. We just covered the epidemiology. We'll go through the pathogenesis of Nafld and the role of obesity and diabetic. And there is a very close relationship between different components of metabolic syndrome and Nafld. And actually, the main pathognomonic feature of all these is insulin resistance. And that insulin resistance tends to be there in obese patients, and patients with obesity tend to have a lot of storage of fat in their liver, and that even worsens the Nafld itself. Once Nafld, the funny things, once Nafld formed, then this makes patients to be more hyperglycemic and difficult to control their hyperglycemia and to control their diabetes, becoming more dyslipidemic and then having hyperuricemias. So there is an interchange kind of like complication or connection between the different components of metabolic syndrome and Nafld. We'll go to the second question. Sorry, Zahir, you want to do the poll? Hello, Zahir. I think Zahir maybe left. So which of the following statement is most accurate? So all patients with Nafld will progress to Nash. You can start voting. Nafld progress to advanced fibrosis higher than Nash. Steatohepatitis is the strongest predictor of Nafld. Fibrosis stage is the strongest predictor of, or fibrosis is the strongest predictor of mortality. Sorry, I think a few words are missing, but they are there on the screen. Fibrosis stage is the strongest predictor of Nafld-related mortality.
Yeah, we're getting great responses. Okay. We have almost 60% responders.
Can end up with the question, Zahra?
Yeah, yeah.
So almost
and,
okay.
We can.
Yeah, so almost equal between equal between the two last, number 3 and number 4, which steatohepatitis is the strongest predictor of Nafld in 45%, and fibrosis stage is the strongest predictor of mortality in Nafld 47. Is actually the right question. The right answer is the fibrosis stage is the strongest predictor of Nafld-related mortality, as we're going to see in the coming slides.
Okay, the same issue?
Yeah, I think so, yeah. But let me, yes.
Okay. Okay, now you can, now give it back. Try to change the slide, Doctor.
I'm trying, but again, Zahir is the same thing.
Can you use the arrows down? Okay.
Yeah, okay. Okay, so that's the, okay, thank you, Zahir.
Yeah.
Okay, so let's go through the pathology, what's happening with there. It's in patients who has got a predisposing factor, such as the genetic background. And I just mentioned a few minutes back, there are more than 60, 70 genes being discovered until now predisposing patient to Nafld. So if a patient have got a genetic background or susceptibility, in addition to the presence of metabolic syndrome, those patients will having huge flux of fat, especially in the form of triglycerides and essential fatty acids going to the liver. And once they goes to the liver, they go certain metabolic changes characterized by decreased fatty acid oxidation and deposition of more fats. In around 25% of those patients, they progress to steatohepatitis. A lot of theory is being put over there, but the exact mechanism is not known or characterized until now. Those patients will have oxidative stress, endoplasmic reticulum stress, mitochondrial dysfunction and toxicity, lipotoxicity, and leading to inflammation, death of hepatocytes, deposition of fibrosis. And once that's tend to be there, then a good percentage of those people will progress to cirrhosis characterized by deposition of more fibrosis. And after approximately 10 to 15 years, around 5% of those patients may develop hepatocellular carcinoma. Another 50%, half of them would require liver transplantation, and 20% may die from liver-related mortality. So this is a very interesting couple of studies. They try to look out what is the source of that fat going to the liver. So they use multiple stable isotopes, fatty acid labeling in patient, and given certain meals, and they did a liver biopsy so they can trace the source of those fats. Where are they coming from? And the three major sources of liver fat is coming either from dietary fat or from carbohydrate that we ingest, or this is coming from basically endogenous fat going to the liver. And surprisingly, the dietary fat that we eat contribute only to 15% of fat present in the liver, around 25 to 26% coming from basically the blood sugar. So, coming from the carbohydrate that we ingest. So between the two, the carbohydrate meals are far worse than fat meals. However, the majority of that fat in the liver are basically coming from adipose tissue through its non-esterified essential fatty acid is carried out through albumin to the liver and get deposited in the liver. There is a strong relationships between Nafld and type 2 diabetes. And actually, of surprise, if you look at the prevalence of Nafld among three major components of metabolic syndromes, such as diabetes, obesity, and dyslipidemia, the prevalence of Nafld in diabetic patients is close to 90%, while the prevalence of Nafld on obese patient is 70%, and the prevalence of Nafld among patients with dyslipidemia is 50%. So type 2 diabetes, those are the patients that we have to focus on and to look for Nafld among those patients. Another important thing, type 2 diabetic patient who has got Nafld tend to have aggressive form of Nafld, which is basically Nash, that tend to progress to higher grade of fibrosis. And those patients are basically difficult to manage from the diabetic point of view. So we covered the epidemiology, the pathogenesis. We'll go through the natural history of Nafld. The good things about it, despite the prevalence of around 1/4 global population that expected to have Nafld, and only a minority of those patients progress to the severe form of Nafld, which is Nash, and then fibrosis and cirrhosis. If you look at those, this slide, which is basically comparing patient who has got Nafld to patient who has got Nash, which is the aggressive form. And the good things about this meta-analysis, it included both the Western population and Eastern population in both sides. So Nafld in both form, Nafl and Nash, they tend to progress to advanced stage of fibrosis. However, the progression in Nash, which is characterized by inflammation, a bit of fibrosis, is almost double the rate. They go from one stage of fibrosis to another stage of fibrosis in around 7.1 years, as you can see here down in the slides, compared to one stage of progression in patient who has got only Nafl steatosis without inflammation. They progress from one stage to another in 14.3 years. So almost it's required double the time to progress in patient who has got just only simple steatosis without inflammation. If we're looking at one of the previous questions, we are basically talking about the mortality, what is related to, is it the fibrosis or is it the inflammation? And this is interesting meta-analysis of 5 cohort studies, including around 150 patients being followed up for quite a good number of years. And you could see clearly that the liver-related mortality goes much faster, higher up after the patient is reaching a stage 2 fibrosis. So in hepatology and the liver biopsy, we got only 4 stages of fibrosis. Stage 1 is the minimal fibrosis. Stage 2 and 3 is mild to moderate fibrosis. And stage 4, we call it cirrhosis. So anybody who has got a stage 2 fibrosis, we consider it to be significant fibrosis, and you can see clearly their mortality goes higher up. So we covered the natural history, and now we'll talk a bit about the presentation. And before that, we'll take another question, Zahir. So which of the following statement is most accurate? We can have the bull, Zahir. All patients with Nafld have hepatomegaly. All patients with Nafld or Nash are symptomatic. Most patients with Nash are asymptomatic, Nafld asymptomatic. Most patients with Nash have symptoms of aggressive disease.
So you can answer the questions on your phone or laptop on that screen by clicking on the answer and submitting. I think majority are going for 2 answers.
Okay.
Shall we stop the?
Shall we stop it? Yes. Yes. Yeah. So I would tend to agree with the audience. Actually, number 3 is the best. Okay.
Yeah. And we share the result now.
Okay.
Okay.
Yeah. So I tend to agree most. Again, so, okay. So most patients with Nafld are asymptomatic. So the symptoms of or the presentation of Nafld, as we just mentioned, majority of them has got no symptoms, and majority of them discovered by a chance. Secondary to major 2 things: either you will get a patient referred to you because of elevated ALT and AST, or you get a patient referred to you because of abnormal imaging on ultrasound, either hepatomegaly or bright liver, or sometimes they call it altered echo texture of the liver. And in a few patients, they may got like incidental hepatomegaly. So whom to screen? And actually looking at the major associations in the world, which is basically including liver and diabetic association, the American Association for the Study of Liver Disease, and the European Association for the Study of Liver Disease, and the American Diabetic Association, all of them agreed on one disease. So diabetes, type 2 diabetes, this is the patients that we have to really screen for. The American Association for the Study of Liver Disease agreed with the European Association for the Study of Disease. Patients with metabolic syndrome should be screened for Nafl. So please, any patient that present to your clinic who has got type 2 diabetes, you have to screen them for the presence of Nafl. So what are the best screening tests or modality? We tend to use liver enzymes and ultrasound as a screening modalities. You have to be careful with one thing here. All reference labs in our country, and I think majority of the countries in the world, they use the upper limit of normal ALT as 40, but in fact that is higher a bit. So the new cutoff value for abnormal or upper limit of normal for ALT is 19 international unit per ml for female and 30 for male. However, ALT and AST are not sensitive. And in fact, they are normal in almost 80% of patients who has got Nafld. On top of that, they are also not sensitive to advanced histology. And around 20% of patients who have abnormal ALT, rise in ALT, when they went up and having liver biopsy and histology, of surprise that histology was a benign without any inflammation or any fibrosis. So the correlation between severity of Nafld and liver enzymes is really lost. What about ultrasound? As I just mentioned, there are a few features that you have to look for, such as increased liver echogenicity, hepatomegaly, and there is another feature called intrahepatic vascular blurring. And this vascular blurring is basically because the rest of the liver is has got a lot of fat deposition. So the vessels with the blood supply, they look a bit blurred. It is not sensitive for steatosis that less than 30%, but once sensitivity goes high up more than close to 80% if the amount of fat covering more than 30% of the liver. If you compare the ultrasound to the other two radiological modalities, such as CT scan, non-contrast CT scan, and a special form of MRI, ultrasound sensitive for steatosis more than 30%, CT scan sensitive for steatosis that more than 10%, and MRI is sensitive for steatosis as low as 5%. Again, in majority of the situation, people with high BMI, it's a bit difficult to do ultrasound on them. So what is the diagnostic strategy? So now you've been referred a patient with elevated liver enzymes, or sorry, before that we have to go for another question. Sorry, I put a lot of questions, so it's becoming a bit more interactive than just to listen to me. So which of the following statement is most accurate? So MRI is the most popular modality used in the diagnosis of Nafld. Imaging cannot clearly distinguish between fatty liver and Nash or predict the degree of fibrosis. The only histologic marker important for the diagnosis of Nash is steatosis, and systemic screening of family members of patients with Nafld is recommended.
I think we reached 62%.
Okay, we can stop it there, Zahir.
Yeah, and
okay.
The results are there.
Okay, so the is actually between 2 and 3. 2 has got 41% and 3 42%. Is actually the imaging cannot clearly distinguish between fatty liver and Nash or predict the degree of fibrosis. It's only when it is advanced fibrosis, cirrhosis, you may changes on imaging. And so that's the correct answer. The only people who have chosen number 3, which is the only histologic marker important for diagnosis of Nash, is not, for Nash, it's not steatosis, it's basically inflammation, which is the most important. So we can go out of that, Zahir?
Yeah.
Okay, so number 2 is the best answer. Okay, so majority of the situation, you will having a patient referred to you because of elevated ALT or ST or fatty liver on ultrasound or CT scan. So what do you do about those patients? So the first thing that you have to look for, do those patients have something called secondary Nafld, which is present in around 5 to 10% presence of steatosis due to other diseases such as heavy alcohol intake. And I put it there, what is the heavy alcohol intake that's been associated with the Nafld, which is more than 30 grams per week in male and 20 grams per week in female. Is this due to hepatitis C, especially genotype 3? Is this due to certain medications such as steroids, tamoxifen, valproic acid? and many other medications, this patient having malnutrition, or this is due to metabolic syndrome such as hemochromatosis, Wilson disease, and alpha-1 antitrypsin. So look for risk factor. Is this patient above the age of 50? Gender of the patient. Male tend to have higher prevalence of Nafld until the age of 50, and then the prevalence goes down. Opposite to the female, tend to have lower prevalence of Nafld until the age of 50, and after menopause, they tend to have higher prevalence of Nafld. Is this patient having type 2 diabetes, which is a major risk factor for Nafld, or having any component of metabolic syndrome? And then is this a simple steatosis, or this is steatosis with inflammation, Nash, or does the patient is basically having some amount of fibrosis? So once you screen the patient for Nafld, now you have to stage those patients. So on the big question mark is popping up once the patient discovered to have some form of steatosis on imaging. So if a patient referred to you, you have to answer two questions. First one, is this patient having simple steatosis, or this patient having basically steatosis with inflammation called steatohepatitis? The second most important question is, what is the amount of fibrosis over there, because this predicts the mortality of those patients. So if you think this patient is having simple steatosis, then what you need is just only simple imaging studies. Ultrasound can pick it up in a less sensitive, CT and MRI are much better. For diagnosis of steatohepatitis inflammation, we always need a liver biopsy. And the most important thing is basically to diagnose a fibrosis. In the past, we used to use liver biopsy even to diagnose advanced fibrosis, but now there are a lot of tests basically available that try to overcome or the need for liver biopsies, and they're called non-invasive tests, and we'll talk about them in the coming few slides. So not every patient will go through the usual pathway from steatosis to steatohepatitis to fibrosis, but you may have a patient that directly for the first time they're having steatosis, and then, from the first time, you may have a patient that presented with fibrosis. So what are these non-invasive tests? These are based on demographic data of the patients, certain laboratory tests, and there is a new technology, we'll talk about it, which is vibration-controlled transient elastography. Those tests are safe, simple to monitor the disease over time, and the advice is not to use cutoff values on one time, but to monitor the patients over longer period of time to get the best answer. They identified patients with advanced fibrosis, while they are excluding patients with early cirrhosis. If you compare them with the liver biopsy, they are cost-effective. And as I just mentioned, instead of using only one simple non-invasive test, the advice is to use multiple non-invasive tests to be more predictive. So what are these non-invasive tests? Before going there, I'll just pose this question. It's a bit of a difficult question, but just try to guess. The two best non-invasive test scores to assess liver fibrosis are, is it FIB4 or Nash fibrosis score? Is it enhanced liver fibrosis test or certain serological markers? Is it FibroTest or Fibrometer? Is it the BOD or the APRI score, AST platelet ratio index?
Shall we stop here?
Okay, Zahir. So okay, this question has, okay, so multiple answers, and some of them, they are close to each other, especially 1 and 3 and 2 and 4 are the same. So basically, the two best non-invasive test score to assess liver fibrosis are FIB4 and Nash fibrosis score. So we'll stop the sharing, Zahir. Okay. Good things, those are free, available on handheld devices, so you can download them in your mobile phones and you can use them. As I mentioned, the FIB4 and Nafld fibrosis scores are the two best simple. They're based on certain demographic characteristics such as age and presence of absence of diabetes and the BMI, and there are certain blood tests such as liver enzymes, platelet, and albumin. For the FIB4, you need only these, the first four, and it gives you a value that range between 1.3 to more than 3.25. So if the FIB4 score is less than 1.3, that's ruled out fibrosis with a good positive predictive value and negative predictive value. For the Nafl, for the NF score, it's range between minus 1.45 and more than 0.67, and it uses all these parameters to calculate the NFS score. So the use of those two scores basically to take you away from the need for liver biopsies. And once you calculate them, you can plot your patient into either low probability of having fibrosis, intermediate, and high probability. If this patient is having low probability of having NAFL, then there is no use for, or there is no indication for liver biopsy. The same thing, if the probability is very high for those patients to have fibrosis, then again, no need. It's used in patient who has got indeterminate value, as we're gonna see later on. This is the new modality machine similar to the ultrasound machine, which based on a technology that transmits certain waves through the liver tissue, and based on a physics that those waves get transmitted faster on harder surfaces. It's a technology has been there over the last 5 to 6 years. We have one machine at the Armed Forces Hospital, and I think the second machine in Oman is available in Sultan Qaboos Hospital in Salalah, donated by one of the companies. So usually patient will have, the operator will have this probe transmit certain waves, goes through the liver, retain back, and they measure the speed of propagation. And you do 10 readings and then take the average. It's good to tell you if the patient has got no fibrosis at all, or the patient having an advanced fibrosis. For the intermediate stage of fibrosis, stage 2 and stage 3, still the operating characteristic of this device is not that great. So for NASH, by the way, each of the diseases has got different values. So the values for hepatitis B is different from hepatitis C from NASH. The cutoff values for NASH patient to say they have got advanced fibrosis, when the value reaching 9 to 10 kilopascal, then you can predict that those patients have a bit of advanced fibrosis. So then how to determine the likelihood of fibrosis in those patients? And this is a very nice bit of graph. So for a patient less than the age of 40, they've got no diabetes and no obesity, and their liver elastography is less than 7 kilopascal, their liver enzymes are normal, then the likelihood those patients having advanced fibrosis is very low, and you just need to monitor those patients. Patient who has over the age of 50, who has got diabetes, obesity, and other component of metabolic syndrome, their liver elastography is more than 8, their elevated liver enzymes, those patients are more likely to have advanced of fibrosis. So by doing those simple non-invasive tests, you can reach to a likelihood of how much of fibrosis is there. So again, now we're going to question number 6. The following statement are true in regard to liver biopsy in the management of Nafld. Is it always required to establish the diagnosis of Nafl? Is the best popular screening method? No sample variation indicated when non-invasive scores are indeterminate. Wow, it's 96. I would tend to agree with the audience. It's basically indicated when non-invasive scores are indeterminate. So again, is the liver biopsy always necessary? No, not always required. And sometimes we need to liver biopsy to confirm the diagnosis, especially if you are in doubt. This is not a simple primary steatosis, or it could be this is secondary steatosis, secondary to viral hepatitis. We have a lot of patients has got two pathologies going on. Hepatitis C and Nash, or hepatitis B and Nash, and sometimes you are not sure if this is Hep B, that elevated liver enzymes, or this is Nash. At that time, we tend to go ahead and do liver biopsy. Sometimes we needed to stage the diseases and to stratify the progression risk. However, you have to keep in mind that the liver biopsy, it's not always the best available test to look for certain elements. Sorry, Zahir, I cannot, okay. So the limitation of this, it's an invasive procedure. It's painful in most of the patients, and it's expensive in a way that you have to have intervention radiology, you have to have a pathologist to look for that, and you will not get answer immediately. And there is a sampling variability. What do you mean by sampling variability? Look at this slide over here. So if the intervention radiology needle goes through that path, the pathologist will see a lot of fibrosis over there, and we may call this one is a stage 4 fibrosis, which is a full-blown cirrhosis. However, if the intervention radiologist put his or her needle over there, there's very minimal fibrosis there, so he may call it like a stage 1. That's what we mean by sampling variabilities, and again, observe variabilities of the pathology depending on what they got from the intervention radiology. And as I just mentioned, you need an expert to perform in terms of intervention radiology, and you need a good pathologist to look at the specimen. So question 7, the most common causes of death in Nafld are they cardiovascular diseases and malignancy, liver cirrhosis and hepatocellular carcinoma, decompensated cirrhosis and hepatocellular carcinoma, is it liver cirrhosis and stroke?
We're getting good responses.
Okay, I think I tricked you with this question. So the most common causes of death in patients of Nafld is not actually liver related. Unfortunately, it is cardiovascular related and malignancies. The second most common one is the decompensated cirrhosis and the hepatocellular carcinoma. So we'll go now to the management of those patients with Nafld. And sorry, another one, but I think already I put the answer there. So we can ignore this question. Which of the following is a recommended treatment strategy for patient with Nash? Is it the drugs metformin or GLP-1? Is it the bariatric surgery? Definitely get 100%. That's the way. It's all of these are basically going for weight loss. So the best answer is the weight loss. So how we approach or how we manage a patient with Nafld. The management lays on 3 principles. One is control of obesity and weight loss. Second thing is to treat the underlying metabolic syndrome, especially type 2 diabetes, so you can reduce the cardiovascular risks. And the third thing is liver-directed treatment. So we'll take one by one of those modalities. So we'll start with the weight loss. And weight loss is basically the cornerstone management of patient who has got Nafld. There are certain criteria and indication when to go for medication and when to go for bariatric surgery. But the fundamental part of this one is basically diet and physical activity. So all patients require diet, exercise, behavior modification. I will not go into deep or what kind of diet, either Mediterranean, low calories diet, different kind of diet. If the patient start to lose weight, then that's what we are looking basically for. If the patient after good duration of diet and exercise, unable to lose weight, or the patient BMI is more than 30 or BMI more than 27 and already having Nafld, then it's advisable to go for one of the medication indicated for weight loss. And the indication for bariatric surgery, it's becoming now popular. And if a patient having a BMI of 40 or BMI of more than 35 and having comorbidities such as diabetic hypertension or Nafld, and you would know for sure that none of these pharmacotherapy or diet exercise will work. Therefore, they should go for bariatric surgery. So let us see how much of weight loss with each of those maneuvers will change in the liver histology, and how many of those patients will sustain that weight loss. This is really an interesting slide. If the patient managed to lose 3%, whatever maneuver they do, lifestyle modification and medication, they tend to improve their steatosis. If they lose more than 5%, the inflammation within the liver, degeneration of the hepatocyte, will improve by 40 to 100%. However, at the end of 1 year, only 1/3 of those patients will be able to maintain the 5% weight loss. If they lose the 7%, the inflammation will resolve in 60 to 90%. However, look at only 18% of those people are able to maintain that weight loss after 1 year. The target weight loss in patient with Nash and Nafld is to lose around 10%, and that will lead to fibrosis regression in close to 50% of people. But see, apart from the bariatric surgery, if they do it through lifestyle modification, see how many of those patients will be able to sustain that weight loss after 1 year is only less than 10%. So those are the indicated weight management medication. I will not go into detail, but I will just touch base on two medication, orlistat, which is lipase inhibitor, and the data is coming only from a small observational study, but till now there is no randomized control trial looking at of Nafld. Sorry, am I clear? Is the voice clear?
Yeah, it is clear, Dr. Khalid. I can hear you.
Okay, I think something happened. Okay, but I think I'm back to the, okay, it's clear now. Okay, and the second medication.
Okay.
Is it okay? So the second medication is the new diabetic GLP-1 medication, liraglutide, which is used as subcutaneous medication. And I will see later on the coming slides the effect on patient who has got Nash or Nafld. A new medication, which is the cousin for liraglutide, is the semaglutide. And it is approved for diabetes at 0.5 and 1 milligram, again, sub-Q injection. And there is already published phase 2 clinical trial on 957 obese patients with diabetes. And you could see clearly the effect of semaglutide compared to liraglutide is actually amazing effect, looking at 10% weight loss in 65% of the patient compared to 34% of patients with liraglutide. Look at 20% weight loss, which is more than what we required for Nash. It is around 27% of patients compared to 4% of patients on liraglutide. However, the exact effect on Nafld is still under phase 3 clinical trial, and no data yet available for that. What about bariatric surgery? There are different kind of bariatric surgery. The three most common known one is the gastric band or the sleeve gastrectomy, or the bypass surgery. And each one, there is a certain amount of weight loss the patient expected to lose with these 2 or 3 types of surgeries. However, bigger magnitude of weight loss with a sleeve gastrectomy and bypass surgery. And in the previous slide, we mentioned what are the indications for patient to go to bariatric surgery if their BMI is more than 40 or BMI more than 35, and they got one of the complications of metabolic syndrome. So what is the effect of bariatric surgery on Nafld? and NASH. This is an interesting paper published in Gastroenterology in 2015. It's a prospective study looking at obese patients with a biopsy-proven NASH. And you could see that after 1 year of bariatric surgery, 85% of those patients had NASH resolution. 1/3 of them had in fibrosis resolution. And in another meta-analysis of 32 cohort studies, looking at the effect of bariatric surgery on NASH, you could see that 66% have got steatosis resolution, 50% has got inflammation or decrease in inflammation, 76% in injury of hepatocyte, and 40%, which is a really quite big number for fibrosis resolution post-bariatric surgery. So the second strategy is basically to treat metabolic syndrome, especially type 2 diabetes and other risk factors. And the recommendation, before going there, we'll take another question. The following diabetic medications are FDA proven for treatment of NASH. Is it metformin? Is it bioglitazone? Is it GLP-1 liraglutide? All of the above, none of the above. Please vote. So majority they voted for 4, which is all of the above. 25% voted for GLP liraglutide, and 20% voted for none of the above. In fact, that's another tricky question. None of those medication is FDA proven for management of NASH. So they're being used as off-label medication and mainly for weight loss, and not FDA proven yet for NASH treatment. So looking at the Endocrine Society, the management of patients with diabetes and Nafld, all of them, they started with lifestyle modification, diet and exercise, then intensify their diabetic medication by trying to use medication that do not promote weight gain, but promote weight loss, such as GLP-1, and then to use medication that have got some effect despite they are off-label, such as bioglitazone. So management of diabetes in patient who has got NASH is really very essential and very important. However, we have to keep in mind those patients or diabetic patient who has got NASH, they are usually tend to be difficult to treat. So bioglitazone in NASH and pre-diabetes, very interesting data. You could see that those patients who's being started on bioglitazone compared to placebo, more than 50% of those patients tend to have more than 2-point resolution in NASH activity score. Half of them, they have got resolution of NASH, and more than 1-point resolution in fibrosis is found in just more than 1/3 of those patients. What about liraglutide when they compare it to placebo in the management of weight loss in NASH patient? It shows excellent results. There is histological improvement in more than 1/3 of those patients. The weight reduction is remarkable and significant compared to the placebo, similar for improvement in liver enzymes. I think in few years with more and more data, this will push the FDA and other big organizations to approve those medications, especially diabetic medication, in the treatment of weight loss and NASH. So what about statin? Do statin really has got an effect on NASH? Until now, none of the statin trials showed any effect on NASH, but we use the statin basically to improve the outcome, or especially the cardiovascular outcome on patients who has got NASH and metabolic syndromes. And the big question mark, and many primary care physicians they got scared when they saw amount of elevation ALT and AT, and not to start those patients on statins. But actually, it's very highly indicated. And you can see this graph patient who's been treated with bioglitazone and has got NASH, and despite there's elevation in initial liver enzymes, and given a statin, the ALT and AST tend to go really down and never picked up. And if you look at the data of hepatotoxicity secondary to NASH, you could see a very small percentage of general population may develop hepatotoxicity secondary to NASH. So it is so safe to start patients on statin. So the third strategy to treat those patients is basically the liver-directed treatment using the two commonly used medication, vitamin E and bioglitazone. And we'll take the last question, which is which of the following statement is true? Bioglitazone may be used in diabetic patient with biopsy-proven NASH. Vitamin E may be used in diabetic patient with biopsy-proven NASH. Bioglitazone may be used in all patients with NASH. Vitamin E is associated with high risk of pancreatic CA. Are we done, Zahir? Okay. So I think majority of the audience between 1 and 3 and a bit higher up going for 1, which I tend to do. For bioglitazone and vitamin E to be started, we always need a biopsy-proven NASH. And that's because of the complication associated with these two medications. And so always biopsy is required. So I would agree, tend to go for number 1. So let us look at those two medications. Bioglitazone, we just touched base on about in the previous slides. It's improving in NASH activity score by more than 2 scores, and maybe using patient with biopsy-proven NASH. Vitamin E, the dose we're using for vitamin E is a bit than the usual dose. The usual recommended dose is 400 international unit. For NASH, we are using 800 international unit. It acts as an antioxidant and do improve NASH by more than 2 NASH activity scores. However, there are certain caveats to that. As I just mentioned, with the higher dose we used for Nafld in vitamin E, there is a possible association with certain complications, such as increase in the hemorrhagic stroke risk. And what is being observed, there is increase in prostate cancer, but not pancreatic cancer. Bioglitazone is being found to increase or basically increase weight gain and some edema. But in spite of that, and in spite of weight gain, it do improve certain aspects of NASH. Risk of osteoporosis, especially in postmenopausal women, is another thing that we have to keep in mind, and increase in the bladder cancer in some studies. So how now we diagnose the patient, we treat the patient, how we monitor Nafld patient, and always try to assess the comorbidity, especially type 2 diabetes and other component of metabolic syndromes. Liver enzymes and non-invasive tests to monitor fibrosis, use multiple non-invasive tests, use them over longer period of time, and don't rely on only one reading. If the patient has only Nafld, and without worsening of the metabolic risk factor, he should be monitored every 2 to 3 years from the Nafld aspect, but not from other component of metabolic syndrome. However, patients who has got NASH and some fibrosis should be really seen once a year minimum. And if they develop cirrhosis, then definitely we should see them every 6 months doing ultrasound, alpha-fetoprotein, checking for hepatocellular carcinoma. And if the patient, there is an indication for liver biopsy and you have done a baseline liver biopsy and the patient is not well controlled, then there is some advice that you can repeat it after 5 years. So if to remember something from this presentation, please concentrate on this slide and remember this slide. This is the most important, the summary and the management of Nafld. So we start screening metabolic syndrome for Nash, especially type 2 diabetes patient metabolic syndrome. How we screen them, as we just mentioned, liver enzymes, imaging, and then use non-invasive tests to characterize your patient or to stratify your patients. Here we just quoted using FIB4 and transient elastography, and then plot your patient into what risk of fibrosis they fall in. Is it in the low risk category? So they require is lifestyle modification and treat the underlying metabolic syndrome. If they fall into the intermediate category of fibrosis, then definitely as a baseline lifestyle advice is required, treatment of metabolic risk factor, and then consider one of the 2 directed medications, which is either bioglitazone if this patient is diabetic or vitamin E if this patient is not diabetic. And before using those 2 medications, it's advisable to have a liver biopsy. However, if the patient already have advanced fibrosis, then again, still there is some kind of like a reversal, even if we reach a stage of fibrosis, by lifestyle modification, treatment of metabolic risk factors, Nafld-directed therapy, and then you screen those patients every 6 months for hepatocellular carcinoma. Back again, last 2 slides on our patient. He's a 54 male with hypertension on lisinopril. He has got high BMI, diabetic, mildly elevated liver enzymes, and dyslipidemia. So how would you manage this patient? Would you order any additional test? Definitely he would require either ultrasound or CT scan as an imaging. If you manage to get some answer from the ultrasound, that's more than enough. Elastography is considered to be one of the non-invasive tests, definitely if you have the luxury. However, as I just mentioned, there are only 2 machines in the entire Sultanate, so it's difficult to get it. Would you require liver biopsy? We mentioned if the patient in the indeterminate category of liver fibrosis, or you are planning to start this patient on medications, then advisable to have liver biopsy. What are his cardiovascular risk factors? He have dyslipidemia, he have hypertension, he have diabetes. Does he have a high cardiovascular? Definitely risk factor. Should it be safe to start statin? Definitely with no question mark. His amount of elevation in liver enzyme, just mild elevation, less than 100. So it is safe to start a statin. What would be the expected benefit of lifestyle intervention? I just mentioned bariatric surgery. His BMI is 36. He has got all metabolic, so bariatric is indicated. If the patient is refusing, is not going, will you try vitamin E? Not because he's diabetic. Bioglitazone is a good choice, or liraglutide to decrease the weight loss. And definitely, if he's cirrhotic, then you have to follow up this patient twice a year for risk of hepatocellular carcinoma. So this is the last slide. In conclusion, Nafld is a very common in the clinical practice of primary care physician, and really carries significant risk of morbidity and mortality, especially non-liver mortality, cardiovascular mortality. I think we are coming to the end, Zahir. Sorry. Okay. We have to screen all patients for diabetes, especially obese patient metabolic syndrome. Use non-invasive test, multiple tests over longer period of time. And I just mentioned, although no medications are proven to treat NASH, but weight loss, vitamin E, bioglitazone can improve steatosis and fibrosis. And I did not show you, but there are more than 35 medications now in the pipeline. Some of them have reached even phase 3 clinical trial for the management of NASH. Thank you very much.
Yeah, thank you, Dr. Khalid, and for the nice presentation. And for that, it is a big topic, and we need to be, as Khalid told, we need to screen because we are getting now increasing obesity in Oman, almost reaching 30% of our adults are obese, and around also 30% are overweight. with the 15% of diabetes, it is a high alert issues. So we get with this issue a question, Dr. Khalid, about do you have any study to look at the prevalence of fatty liver disease in Oman?
Unfortunately, no, Zahir, and that was what I was talking to you yesterday. Actually, we are in the process. I involve you with some questionnaire that sent to us by the European Association for the Study of Liver Disease. And they are taking the initiative of looking at the prevalence in different parts of the globe. So they divided the entire world into subcontinents. They already published their data on Europe, but till now there is no data from this part of the world. I think if I do remember, there's some data from combination of Saudi Arabia and Emirates. They published their prevalence, but not from Oman.
Correct. And about is it common in pediatric age group? I mean, the Nafld, and with the growing obesity also in our population in the pediatric age group?
Very interesting question. Yes, actually, the prevalence of obesity in the pediatric age group is really increasing and associated with the presence of Nafld and the concentration now from the pediatric hepatologist even to start screening obese kids for Nafld. The things that if you go about the presence of diabetes, especially type 2, is less prevalent compared to type 1 in the pediatric age group. So the diabetic type 2, the contribution of type 2 diabetes in the pediatric age group is not as high as obesity to contribute to Nafld. But the prevalence is increasing, both obesity and Nafld in the pediatric age group.
Yeah. So I mean, like you get a patient like with obesity and diabetes, and then his LFT. What are the cut values to say like on the ALT? It is like we need to consider, I mean, Nafld.
So there is no cutoff values for Nafld, but in the majority of the situations, Nash will not exceed a rough ALT of 300. Some being described up to 500, but that's very rare. Majority of the situation is to an ALT of 100. The most important point to keep in mind that sometimes a patient coming to us and their value is 35 or 40, and it is within the standard reference in our country, and we call it normal, but in fact, that's not normal. Very interesting. The initial values of ALT and AST of 40 came from data in the early 80s, when basically hepatitis C is not known at that time. Nafld is not known at that time. So they took the cutoff of 40 as the upper limit of normal. Later studies in 1991 by the Korean group published in British Medical Journal showed that patients who's being considered to have normal ALT between 30 and 40, their mortality is much higher than patients who have ALT less than 30. So for myself, anything in male above the age of 30, anything in the female above the age of 20.
So the question here, the second question that you get like raised liver enzyme.
Sorry, I couldn't hear you, Zahir.
Okay, just to finish up the question, I have another question. I mean, you said from your opinion.
Yeah, from my opinion, the majority of those patients is basically their elevation liver enzymes is very mild. The most important thing when you get a mild elevation in liver enzymes is check for any underlying liver diseases. And the common thing is basically viral hepatitis here with us in Oman. Hepatitis B is the most common, followed by hepatitis C. Metabolic liver diseases is so uncommon here in Oman. Rarely to get a hemochromatosis. Few patients only in the entire country has got Wilson disease, and haven't seen myself any patient with alpha-1 antitrypsin. So check for viral hepatitis. Check for medications, herbal medications, other medications. If they are not there, and then basically go for ultrasound.
Yeah. So if you got the ultrasound with the fatty liver, I mean, res ultrasound with hepatitis negative screen. So what's the second level of care you need to look at your patient? I mean, consider statin therapy if it's dyslipidemic and weight, or what will do?
The second step is basically to stratify your patient. Does this patient having a simple steatosis? Does this patient having steatohepatitis? And the most important thing is basically, does this patient having fibrosis? So use multiple non-invasive tests, the FIB4, the Nash score, fibrosis score. You can plot them on your mobile phone. You get category. This is an low basically risk for advanced fibrosis, intermediate and high. If this patient having low, you start basically by lifestyle modification. You can definitely add a statin, promote weight loss, such as diet, exercise, and look at their BMI. Do they fall in the category of that requiring bariatric surgery or basically medication? So the first step after identifying liver enzymes elevation and ultrasound is to stratify your patient if they do have fibrosis or not.
Yeah, and the second question here, I mean, how to differentiate in primary care between hepatocytosis and steatohepatitis? As the last one requires liver biopsy. Between hepatocytosis? Between
just simple steatosis and between steatohepatitis, the only one is liver biopsy. Until now, all of those non-invasive tests being created to look fibrosis, but not to look for inflammation, which is the steatohepatitis.
Yeah. So another practical question from Hajar. I mean, so you've got like ultrasound proved with the liver enzymes to start weight reduction program. I mean, shall a primary healthcare physician, follow up the patient, or he need to refer to hepatologist for further evaluation?
This is really very excellent questions. There are countries in Europe, and especially United Kingdom, they start to create their flow chart for their primary care physician when to refer the patients to the hepatologist. And this is because of the limited number of hepatologists around the world. So, and to be honest with you, and primary care physician even better than hepatologist for the management of lifestyle modification and other component of metabolic syndrome. When to refer, if there is any doubt, this patient may have steatohepatitis, or definitely if by plotting non-invasive tests tell you this patient has advanced fibrosis, please do refer them.
Great. So, do you think that we need to do like a primary, like a national guideline on the screening and management of Nafld?
Well, this is my dream, which is the time. You just, Zahir, few minutes back, you said we have got prevalence of obesity of 30% in Oman, 30% pre-obese, and 15% diabetes. There is definitely a need for coming up, even if it is not a guidelines, but a flow chart, what to do and how to do it, and when to refer and whom to refer to.
Okay, with the high cardiovascular risk with the Nafld, do you recommend starting statin like primary prevention?
Sorry, back again, Zahir. If the patient having what? Sorry.
With the high prevalence of dyslipidemia in Oman and with the Nafld disease, do you recommend to put the client on statin?
Yeah, there is one issue we have to keep in mind. Until now, statins are not proven for the treatment of Nash. Is not even the observational trial like vitamin E or bioglucosone. Statin is to modify the risk factor, especially the metabolic syndrome component, and to decrease the risk of cardiovascular mortality, which is the first or the common cause of death in patient who has got Nash. So if there is an indication from the dyslipidemia point of view, please go ahead.
Can we add the Nash to the cardiovascular risk scoring system? I got a new question. The cardiovascular scoring system contains like lipid, LDL, cholesterol, and other issues. Is it the time to add it to the scoring system?
Yeah, it is very interesting question, and until now, some of the hepatologists expert in Nash, they are calling to add Nafld as one of the 5 components of metabolic syndrome. Okay. So there is a push from international societies. And I remember yesterday I was talking to you, Zahir, and there is a huge move in hepatology from viral hepatitis because we found medication for hepatitis B and hepatitis C. And there is a huge move now toward Nash.
for public awareness, governmental awareness, and physician awareness about this disease, and should be even incorporated in all cardiology guidelines, diabetic guidelines, endocrine guidelines. So I think you would see in the coming 5 to 10 years that Nafld or Nash becoming a major component in all of these guidelines and risk scores.
Yeah, and the question about the scanning, methodology. Which is better to use, like FibroScan or the SWE scan, the shear wave elastography for liver fibrosis?
The FibroScan and the shear wave is the same one, different names for the same machine. So it is, it's basically measuring two things. It's measuring the amount of fibrosis by giving you a value of kilopascal. And as I mentioned, each disease has got its own cutoff values. To call somebody has got a bit of advanced fibrosis in Nash, we required a value close to 9 to 10 kilopascal. The device has a software that can measure amount of steatosis and called CAB steatosis. And anything more, a CAB of more than 250 to consider this patient having a bit of significant amount of steatosis. However, it is a new technology, still no much of data. And as far as I know, there is a lot of trials going on comparing now the CAB steatosis in this machine or in this technology with the reference gold standard, which is either MR elastography or liver biopsy.
Great. And one of the attendees wanted to emphasize on the diet issue about type of fat to be used on cooking. Is it wise to use the plant oils or the animal oils? Any difference between the fully saturated or unsaturated fatty acids oils on the cooking? Do you recommend?
Yes. So looking at latest data, a few years back, which changed the entire practice of cardiology, and I think I presented over here. In regards to Nafld, whatever we eat is only contributing to 15% of the entire fat in the liver. 30% is coming from the carbohydrate that we eat. So carb is much worse than fat that we eat. And 60% is coming from the endogenous lipogenesis and mobilization of fat from adipose tissue going to the liver. So how much of fat contribute is only 15%.
Okay. And can you comment, Doctor, on the effectivity of silyamarin for Nafld? From Dr. Tristan, a question.
Yeah, it's basically the data is still more and more evolving, and we are expecting more data to be published in the coming few years. And as I did not quote one of the slides, which I just mentioned, showed you more than 25 to 30 new medication in the pipeline, and this is one of them reaching already higher stages of clinical trials to get an answer. Most of these, and you see just only with liraglutide, semaglutide, there is huge difference in terms of when you compare them to the placebo in terms of normalization or improvement in liver enzymes, improvement of histology in terms of steatosis, in terms of inflammation, and improvement even in fibrosis. So I think the future is more and more brighter, and we're having medication that hopefully can treat NASH without going for major surgery such as bariatric surgery.
Great. The final question, Dr. Khalid, to give you a rest time. So any relation between NASH and hepatitis A and D and F, with other hepatitis? Is there any
Excellent question. Excellent questions. Yeah. So the part of the hepatotropic viruses, the only association so far is with hepatitis C, especially genotype 3. Hepatitis C genotype 3 has been associated with NASH, and this information, we know it for the last 20, 30 years. Is there any association between Nafld and hepatitis A or E? A and E tend to be an acute hepatotropic viruses, mild effect. They don't usually cause Nash or Nafld. What about hepatitis B, which is a chronic hepatitis B? There is no much of data on that one, but based on our clinical daily practice, and we have close to more than 1,000 patients who are following with hepatitis B, quite significant number of those patients have the coincidence of both hepatitis B and Nash. And actually, I raised this question to few people. I think myself, we should do study on those, checking their background, checking the effect of hepatitis B, since it's a DNA virus, when get inserted into the human genome. Does it do any alteration of the human being genetic background to promote Nafld, especially now more than 60, 70 genetic alterations has been published and discovered that can contribute to Nash. So the question is Hep C genotype 3, yes. Hep B observation, A and E is not.
Great. Thank you, Dr. Khalid, for the time spent with us. And it is more informative lecture. And it is also like an alert to the public health also and primary healthcare physicians to look at the increasing prevalence with the fatty liver in association with obesity and diabetes in Oman and other countries. And it is like an alert to the decision makers to start intervention as community-based intervention and also patient-based intervention to reduce obesity and then to manage and screen fatty liver disease. And it is like and also like a push up to start like a national or protocol or a guideline on or a pathway on the management of the fatty liver and screening, so we can get less complication and start a proper patient flow of our clients. Dr. Khalid, thank you for the informative speech, and we'd like to thank also the audiences for the time spent with us. And we are going to meet Dr. Khalid soon also with the hot topic on hepatitis, chronic hepatitis management and primary health care. It's like a hot topic and a lot of discussion, a lot of questions there. When to screen, how to follow up, and when to refer also to our colleague gastroenterologist and the secondary healthcare. By the end, you will get like, when you close the screen, you will get like a pop-up message. Please fill up the evaluation form, and soon you'll get your certificate on your email, inshallah. And second talk will be next week about the common ophthalmic eye disease and approach in primary healthcare. See you then next, and follow-ups on the Twitter and our YouTube channel. And Dr. Khalid, do we have final words?
Thank you very much, Zahir, and thanks to the organizer of this activity. I'm really thrilled and impressed with the activities being going around, and I totally agree with you. I think we have to initiate the first step. Yesterday, I was talking to Zahir, for those who are listening to us. I think, and we are on the process of doing some research related to Nafl. So for those who are really interested, either they can contact Dr. Zahir directly or contact me. And I 100% agree that we have to start, especially with this high prevalence of obesity and diabetes in Oman. Thank you again, and all the best in the coming activities.
Thank you, Dr. Khalid, and keep active to prevent fatty liver disease.
Thank you. Thanks.
Okay, goodbye, Khalid.
Thank you. Thanks. Bye. Thank you. Assalam.
Thanks a lot. Bye.